And now this patient has to be taken up for revascularization. We all know that in acute myocardial infarction, we prefer revascularization preferably within 6 hours and definitely within 12 hours. But cardiogenic shock we know is actually different, and we may actually revascularize much later. And how we should revascularize, when we should revascularize, I think we have a speaker no better than Dr. Asfaqm Ahmed. So you can please start your presentation.
A humble request to all the respected speakers and the panelists, that is, since we truly want to adhere to the time limit, if we can have the discussion at the end of each session, that will really help us managing the time in a better way. Thank you for understanding. Let us finish all the talks by all the respected speakers first. Then in the residual time, if you can kindly take forward the discussion, that would be really great. Thank you for your understanding.
Thank you, Devanu sir. Thank you, CSI, for giving me this opportunity to speak on a very relevant topic, a kind of patients we deal almost every day. On every on-call day, we have one of these kind of patients. Dr. Gopal has nicely put how to manage medically. And even after managing medically, we see there is high mortality in these patients. So we always feel that we should do something for these patients in terms of revascularization. And if that is not working, or along with that, we can help him with some kind of mechanical circulatory support. So let us see, as Gopal has discussed about the incidence of cardiogenic shock and the mechanical complications. I will not go into the details of this. Let us start. If we are planning to take these patients for revascularization, access site first. The current guidelines recommend a radial access site as a default strategy in non-shock STEMI or non-ST elevation ACS and stable CAD. In cardiogenic shock, the beneficial of radial access is less evidence-based. We do have multiple gadgets. We want to take bigger sizes devices. So maybe femoral access is still valuable alternative in these patients. What does the shock trial say about the immediate versus delayed PCI? The shock trial, it actually failed to meet the primary endpoint, that is lowering 30-day mortality with revascularization in comparison to initial medical stabilization. However, there was a significant mortality reduction at a longer follow-up in these patients, say around 6 months, 1 year or so. And the widespread use of early revascularization in multiple registries have confirmed that there is a significant decrease in mortality from a previous around 80% to approximately 50%. So recent registries suggest a detrimental effect of revascularization delays on outcome. Coming to multivessel PCI versus culprit artery PCI, recently the randomized multicenter culprit lesion only PCI versus multivessel to the culprit shock trial, it showed that a significant clinical benefit of a culprit lesion only strategy. And the reduction of the primary endpoint, and that is the 30-day mortality on RRT, was only 45% in PCI as compared to the immediate multivessel PCI in all the vessels. And absolute risk reduction was approximately 8.2% mortality. Peri-interventional antiplatelet and antithrombotic medications, there are no specific trials in cardiogenic shock. But here we need to mention that in cardiogenic shock, there is the hemodynamic milieu and the general systemic condition is such that the internal absorption of oral medications are not adequate. So in these kind of patients, we do can have IV antiplatelets like Cangrelor can play a role. And if the patient is on nasogastric tube, we must crush all the oral antiplatelets before putting it through the nasogastric tube. So the DAPT shock MI trial, which is about to be completed in 2024, the IV Cangrelor is currently used in AMI with shock patients. We'll have to wait for the results to come out. And we usually, in cardiogenic shock, if there is a high thrombus burden or a slow flow after PCI, we routinely use GP2B, and that also gives a very good results. And adjunctive intravenous anticoagulation should be co-administered with antiplatelets depending on the patient's condition and the physician's choice. ICU treatment, as very well described by Dr. Gopal Ghosh, we'll skip this part. Now coming to the mechanical circulatory support devices, these are the mechanical pumps which are designed to assist or replace the function of either of the ventricle or both ventricles at a time when we are unable to meet the demand of the metabolic demands of the body. So if you look at the currently available types of mechanical circulatory support devices, talk about the left ventricle support devices first. There is IABP, which is most commonly used, and we have been using it almost in shock patients. Around 40-50% of shock patients we do put an IABP. Cost effective it is in cases of revascularization and in terms when other if it is compared to the other mechanical circulatory support devices like Impella and ECMO. So the cost is the only factor which limits us. But if we're given a choice, we would like to use Impella via ECMO more often in patients of cardiogenic shock. For the right ventricle support also, there is Impella RP and tandem heart RA to pulmonary artery, and a VA ECMO can be used. So the maximum benefit we get from the Impella and the VA ECMO, the flow is much higher in comparison to IABP, which is giving approximately only 1.5 to 2 liters of support. Access wise, femoral artery is the preferred access in all these cases. So there are various advantages, disadvantages of all the devices, but as such, these patients cannot be randomized. These patients are very difficult to put on a randomized trial and putting on head-to-head comparison with other devices. So it all depends on the institute's availability of the device and the physician's choice, and as well as the cost. So a patient with chronic heart failure is more likely to respond to IVP rather than in acute cardiogenic shock. And a study of temporary MCS in decompensated heart failure has been even more challenging than acute myocardial infarction and cardiogenic shock due to the diversity of etiologies of shock and the etiology of decompensation. So these devices, actually, we are not putting it from trial. These are expert opinions and few centers, small trials of few patients, which we have data, and we can accumulate this data and use it according to the need of our patient. In the Impella Euroshock registry, it was one of the first studies evaluating the outcomes with the use of first generation Impella. And investigators evaluated outcomes in 120 patients and found that the use of Impella was associated with reduced lactate level, suggesting improved systemic perfusion. But overall mortality was still very high. The US Impella registry came, which evaluated around 150 patients, and this had a better survival than the previous studies. And patients who were treated with Impella pre-PCI, they had a survival of 65% in comparison to those who were treated with post-PCI. So other studies also showed similar results. We take on upfront Impella and then we go for PCI. The ISA shock trial included 26 patients and demonstrated physiologic improvements with the use of an Impella compared with an IBP with no difference in 30-day mortality. The IMPRESS trial also is a large randomized trial and had 48 patients, and it demonstrated also no difference in mortality at 1 month or 6 months follow-up. If we compare Impella with IBP, definitely function-wise Impella is better if we do not consider the cost. Sharch et al. Matched patients from IBP Shock 2 trial to patients supported with an Impella device using a large European registry, and it demonstrated that there was no significant difference in a 30-day all-cause mortality, but did demonstrate higher rates of severe bleeding and vascular complications in the Impella arm. The study in Sharch et al. Study, the degree of cardiogenic shock was not taken into account when matching patients. And Hilgested et al. Were able to control for the degree of shock in their match analysis that included controlling of age, LV ejection fraction, lactate levels, and kidney functions. And this also demonstrated a lower 30-day mortality in patients receiving Impella when compared to the IABP group. So continuing with Impella versus IABP, the strongest evidence of the use of Impella in cardiogenic shock following MI comes from the Cardiogenic Shock Initiative. It was done in more than 400 patients, and the 30-day survival was approximately 70% in these patients. Coming to the other device, that is tandem heart therapy for MI with cardiogenic shock. There was a small study with 41 patients, and despite markers of hemodynamic improvement favoring tandem heart, the mortality was almost similar with tandem heart versus IABP. similar study of 42 patients with tandem heart versus IABP. They demonstrated improvement in hemodynamics in the tandem heart, but overall difference was not there. And this was again the study with tandem heart versus VA ECMO. So in this also the survival group, both groups were almost similar at 30 days. There is no difference in the need for RRT, stroke or recurrent MI. So more or less we see whichever method we use, the overall 30-day mortality remains same, except from the one data where Impella shows a better mortality and Impella pre-PCI is better than in Smith et al. Analyzed 55 patients, 29% of whom had AMI with cardiogenic shock. And in this study, survival was greatly influenced by the indication for use of tandem heart with a survival of 23% when used as a bridge to recovery and 51% when used as a bridge to LVAD or surgery. Coming to VA ECMO therapy, there are limited data on this also. There was a prospective study in 2019 and the outcomes of 51 patients treated with VA ECMO or Impella following shock. And this required an increased number of vasopressors, VA ECMO, and were more likely to have an IABP in place when compared to patients treated with Impella. And survival to discharge between the cohorts was similar, 50% for VA ECMO versus 63% for Impella. So overall, if we see the most of the data do not favor any one device for putting in cardiogenic shock. It all depends on where the patient stands and what the physician thinks will be good for the patient. I'll skip these. The main was the culprit shock trial, which showed a significant clinical, as I discussed earlier. So my take-home message from this patient when choosing a MCS device, it depends on the etiology of shock, the stages of shock, and the patient's age. And with continued advancement, these devices will continue to become smaller and more powerful. Thus, we'll have to be familiar to use it, how to use it, when to use it. These decisions remain on the physician and the condition of the patient at the time of intervention. Thank you.
Thank you, Dr. Asfaqm. I think that was a very nice presentation. You have discussed actually all the options available to us before we go for revascularizing these patients. Actually, maintaining the hemodynamics is very important. And as we have clearly shown, that the mortality, which was 70 to 80%, has actually come down to now 50%. And today we have options of IABP, we have option of ECMO, and we have options of Impella. But at the same time, I would like to mention that these are extremely costly treatment, and mortality still continues to be 50% plus even after the use of these devices. So we must be very judicious in our decision that what to use and what not to use. And medical treatment becomes very, very important.